Yes, I'm very pleased to talk about light sedation today. So I would say that we need light sedation because we don't want this anymore. We don't want our patients lying in a bed immobilized. We need to have an early extubation of our patients, an early mobilization, and finally, we want to have an early ICU discharge or hospital discharge to their house. But to do so, we need to get the sedation lower and lower. How to do this? Jean-François said that we need to use algorithms. To do so, we need to use algorithms based on nurse protocols and to use daily sedation interruptions. We need to have the right target sedation and we need to use the right molecules. For sure, we need to avoid benzodiazepines and maybe you should promote propofol or dexmedetomidine. And this must be an analgesia first based sedation. I would go further, even further, and be kind of provocative. Could we avoid any sedation in our ICUs? First study is an old study, 10 years ago in Denmark. They tried to avoid any sedation and they compared the group of patients without sedation to a standardized sedation with propofol and midazolam thereafter. Those patients were mostly medical patients and severely ill medical patients. What they found very quickly is that, yes, it is possible and you can avoid mechanical ventilations. You can spare days of intubation and mechanical ventilations in such a way. There is a major limit in this study is that this is in Denmark and the nurse-to-patient ratio is 1:1 and actually they needed extra person to calm patients without any sedation. What about our surgical patients? Usually we take the severe surgical patients in the ICUs and we keep them sedated because they might have pain or severe diseases. I would like to present you the SOS ventilation study made by Gérald Schank in Montpellier. And what they did is that starting from severe abdominal postoperative patients after abdominal surgery, they had some organ failure and they needed at least 12 hours of mechanical ventilation. They randomized those patients to two groups. The first one, they had an immediate interruption of sedation at ICU entrance, and the second group had continuous infusion of sedation with a daily interruption protocol. For just a point, an interesting point is that most of those patients were severe patients with high lactate levels, and they had most of them vasopressors. What they found is that if you stop the sedation at ICU entrance of those patients, you can extubate them about 8 hours after the entrance, and the other group, it was about 50 hours, 2 days of intubation for nothing finally. Interestingly, there was no complication and not much more need for reintubation, NIV, or tracheotomy in both groups.
Maybe we can have just a quick stop at this stage. I'm not sure the message no sedation is clearly correct. Probably we can summarize and say that we can try to give no sedation,
right.
But even in the no sedation group from STROM, 30% of patients receive propofol.
Right.
So I think the good message is we need to try to give no sedation. We should give no sedation, but it's not so easy to do. You agree with that?
I do totally agree, yeah.
Okay, so sorry, move on.
May I have the slide, please?
The slide disappear. Hi.
Yes, thank you. So finally, my key message is that maybe we can avoid any sedation, but we need to look at light sedation. But it requires algorithms, it requires the right molecule, and so on. And this is feasible in medical and surgical ICUs, and this might be combined with potential benefits for our patients. But one point is, finally, the real question is, yes, my patient deserves a light sedation, this is for sure, or maybe no sedation, but there is still a remaining question which is more tricky, is that, do my patient really need a deep sedation? And to go further, the point is that we still don't know which molecule is the best. Propofol, dexmedetomidine, we don't know for nowadays.
Okay, thank you, Thomas. Maybe we can discuss now about the issue about dexmedetomidine in ICU. I believe, and I think a lot of experts believe, that dexmedetomidine could have an added value for patients, maybe because it's really easy to give light sedation with dexmedetomidine, because you can't give deep sedation with dexmedetomidine. But a recent paper, the result of a recent trial of our friend from Australia, or is confusing at least. What do you think about the SPICE-3 trial and the results of the SPICE-3 trial?
Maybe I could have my slides back, please. Yes, indeed. The SPICE-3 study is very, very confusing one, because it was, they included 4,000, sorry, I'll go further. They included 4,000 patients, and they randomized them in the dexmedetomidine group or the usual care group using propofol, midazolam, or other sedatives. And what they found is that there is no difference in terms of death from any cause at 90 days. But there is a huge caveat to my opinion in this study, is that actually 60% of patients had a clinical indication for deep sedation in the first days of this study. So using dexmedetomidine in patients needed deep sedation, this is the wrong solution actually. If we look at the patients in the dexmedetomidine group, most of them had propofol. So using dex plus propofol and maybe neuromuscular blocking agent, there is no use to do so.
It makes no sense, at least. I don't know what you think about that, Jean-François, but
I totally agree with this statement. And also less than 25-30% of patients achieved the target sedation levels in this study. So I agree. This study made confusing statement in our community, and I think that on the reverse, Dex is a useful drug for getting light sedation. Yeah.
In the algorithm of the SPICE-3 trial, the indication of deep sedation was given by intensivist, and I think the main message of this trial is that when you give the choice to doctors in the ICU, most of the time they give deep sedation without any indication. So
exact.
It's not an issue with the drug; it's an issue with the indication of sedation. Right. Other discussion about this trial, Thomas?
No, it's okay.
Nothing new. So maybe to move on.